Welcome to Clinic Success Secrets. Today, I'm honored to have Irina Koyfman on, and we've got a really exciting conversation ahead of us. We're going to dive deep into chronic care management and remote patient monitoring. Irina, amongst many other things, is an expert in these two topics, and I'm really looking forward to diving into it with her. But first of all, with all this being said, thank you so much, Irina, for joining us today.
My pleasure, Thomas.
So Dr. Koyfman, I suppose before we get into this, could you please explain what chronic care management is, along with remote patient monitoring, and how do those roles, play a part when it comes to transforming patient care, in clinics?
Sure. I'll probably just take a step back and tell you who I am and how I got into it. So people will hopefully trust me. I'm a nurse practitioner with a doctorate degree and also entrepreneur. So all through my careers, I was interested in, opening and maintaining and selling businesses. They were all in healthcare. But I also have a tremendous experience in, big corporate Americas. I worked for large insurance companies. I led clinical teams, and with all that information, I kind of started looking, being a nurse practitioner and hearing from my friends in the industry, doctors and PAs, how there's so much work and keep in mind, this was pre-COVID, before telehealth. So much work that's being done in between patients' visits. Patients call and ask, they forget, oh, tell me again, why did you prescribe this medication? Or I'm having this side effect, I'm not sure. Or you ask me to see a neurologist and I can't find the clinic. Or I lost my lab slip and I need one more. So all the stuff that we as providers have always done in between visits, but there was never a way to get paid for it. And being an entrepreneur, like I was always looking for things to improve, and I stumbled upon chronic care management as a CPT code that was designed by Medicare in 2015. Um, and I was like, whoa, that's what it is. This is basically getting paid for all the work that's being done in between office visits. So I dig really deep into it. And what I realized is that that's exactly why Medicare design, it was initially just two codes, one for the 20 minutes and one for 60 minutes. It was pretty cumbersome. You had to get actually written consent. So you had to see patient face to face, talk to the patient, get them to sign. Care plan is pretty long, and the payment was very little. It was literally like $20 or something for 20 minutes. So there's always early adopters. Some doctors really got on the bandwagon. They start doing it, they start billing it. A lot of people then stop doing it because they were like, oh, it just takes too much of my time. Well, by 2017, Medicare already had the data, claims data, and they reviewed it and they said, whoa, everybody that got billed for CCM codes, patients had better satisfaction, providers had better satisfaction, clinically there were better results, but also what does Medicare really cares for? There was cost savings. So then Medicare were like, whoa, we're on the right track. So they added more codes. So by 2019, they added, a few more codes. They added another program. I'll talk about that a little later. And then of course COVID hit. So then everything became, as I said, everything kind of telehealth became super sexy. And then it just blew up. I became a subject matter expert in chronic care management because by that time everybody wanted to know how can I do it, because people were still providing patient care. But this is an extra, I always say this is extra layer of support, but also extra revenue stream for the providers. And the biggest change happened in 2022 when Medicare actually increased the fee schedule, but about 50%. If you've been in Medicare space, you know that the only news we usually get is, fee schedule decreases a little bit. This was probably the only thing that Medicare increased the fee schedule, and then it like totally blew up. So now for the 20 minutes of chronic care management, CCM work, we can bill like Medicare pays $64 for 20 minutes. So it becomes close to $200 per hour, and they're allowing clinical team to do the work. So you as a provider don't have to do it. You can if you want to. The reimbursement is a little bit more, but it requires more time on your part. But providers usually outsource that. They either hire MA or LPN or outsource it to the third parties. and then get that service done. So it's very financially beneficial for providers to add chronic care management. It's extremely beneficial for patients because patients just love it. And of course, I have so much to say about it and how to not make the bad decisions of maybe outsourcing it to the team that are not clinically strong, because everybody gets paid almost the same. So you might as well find the best possible, bang for your buck. And I love working with nurses. And when nurses provide that care, I mean, patients love it. They're like, oh my gosh, they get their dedicated nurse. The nurse calls them, once a month, at least, a lot of times more, but it's not about the call. It's about all the work that's being done in between. They can, go over the lab results with patients. They can ask, they can get refills for them. They can call the pharmacy, like care coordination, social determinants of health, all the stuff. This is all chronic care management. So it's an amazing, it's not really not a program, it's just CPT codes, but people call it program, so I'll call it program. It's an amazing program, amazing addition. And if your clinic, if you own the clinic or you're working in the clinic and you're not providing chronic care management and or principal care management, which is really chronic care management, but just for one disease. So let's say your clinic that does only weight loss or sleep. You can do essentially the same thing, but focus on one disease. It was designed by Medicare a few years after CCM because a lot of specialists were like, whoa, we really like this, but we're not primary care. We're not managing all of the diseases that patients have. So Medicare came up with that principal care management, which is essentially CCM, but for one chronic disease. And the payment is about the same, but the time commitment is a little bit longer. So you get about $64 for half an hour. So it's not as lucrative, but it's still the way to make money by providing extra layer of support to your patients, and patients truly love it. And I'll come up for air and maybe you'll ask me questions and then I'll talk about RPM.
Okay, first of all, thanks so much for that comprehensive explanation. I think it really does sound like a bit of a hidden gem when it comes to
Mm-hmm.
number one, providing that um ongoing care for people. And we obviously want to talk about RPM, but as you said, it's especially in an age when telehealth and everything like that is really kicking off. Um, it's a no-brainer. It's an extra source of revenue. People are clearly crying out for it. There's product market fit, so to speak, and chronic pain is it's nearly a buzzword at the minute. Everyone, it's really come to the forefront of the public. So I mean, if you have the capacity, if you have the team to implement this, and I'm sure you're going to elaborate upon how that can be done. It really does seem like a no-brainer to me based on everything you're saying. Um, with that being said, Irina, you know this all sounds well and good, but are there common challenges that clinics often face when it comes to integrating CCM into existing operations? And are there ways around that you can recommend?
Yeah, yeah. And I'm glad you asked because it's a hidden gem, but it's not like um I guess maybe it's not like hunting for truffles where you spend all this time hunting and then you got a truffle, you're like, oh wow, I got $1,000 worth. It's really the the devil is in the detail. So knowing that it exists, the important part is to really understand the program and implement it correctly. So what I see a lot of clinics do is they outsource it, because what happens now is, if you're a provider, you probably got a call in the last month or even a week from either CCM or RPM company saying, hey, work with me. Just give me the list of your patients. They always tell you the money right away. It's about, $1,000 per patient per year. If you give us the list of 10,000 patients, you make whatever, $1 million, and, we take half and we do this. And it sounds tremendous. And a lot of those um, third parties will say, there's nothing that you have to do. Like literally nothing. It's a white glove. We take care of everything. Well, imagine for a second, Thomas, that you're a patient and I'm your doctor. And now you get a call from Nurse Emmy in another state. And she said, hi, I work with Dr. Koyfman, and she's providing the service that I will actually, I will be the one talking to you. Well, and you'll be like, well, okay, great. Where are you? Well, I'm in Alaska. Well, what do you know about Dr. Koyfman? Nothing. Do you have access to her EMR? No. So it gets so fragmented, and a lot of times it just adds an extra layer of complexity to the patients. So my always, I would say what I say is it's literally the best if you can actually do it within your clinic. You understand the program, you get the special software. I'll talk about that. You don't have to, you can do it in your EMR, but you hire somebody, hire them full time to do it. Don't say, oh, my MA can add that on, because the job is not going to get done and you won't be able to bill because it's time commitment. You can only bill if you have documented 20 minutes of whatever, care coordination, something. That's why I like softwares, because softwares have the timer built in. So there's no guessing. You're not writing on a piece of paper. You're not, afraid when Medicare will come with audit. They'll say, well, how do you know that you spent 20 minutes? How was the 20 minutes spent? So like there's a pros and cons to use the platform. It's not cheap, but, and then I'll talk about that because some charge, per patient per month, some charge monthly fee per provider. So there is a way to, demo look at it. But platform aside, um, the second best is if you outsource it, and you outsource it, it has to be a reputable company. Um, you wanted to probably make sure that they mostly hire LPNs. And I love medical assistants. MAs are great. However, they've never been trained in like care coordination. They haven't been trained in medication adherence. And so if you're paying the same money, you might as well get the highest license you can get for that money, right? You can't get an RN because RNs are too expensive, but LPNs are fantastic, and you can teach them to do the work. You want to make sure that that clinical team has a good management. I'm saying that with a smile because I remember talking to one nurse that called me and she said, I need to leave my job. She was working in CCM, outsourced company, because they hired a manager who was, Thomas, who do you think the hiring manager for nurses was?
You'd have to tell me. It could be anyone. Put a smile on your face.
Veterinary technician.
Okay.
Veterinary tech was hired and maybe it was a fantastic manager, but as a nurse, you cannot report to veterinary tech. That just doesn't make any sense. So you want to make sure that the team has a really good management, and management has to be clinical, because when things happen, patients call with questions and with issues, and your nurses or LPNs or MAs cannot handle it. You want the next step, like who is the, more knowledgeable. You want to make sure the company has either bilingual people or they have a language line, because I'm sure anywhere you are, you have people that, as a provider, you might have to use the language line. And you'll be surprised how many, if you ask the vendor, like, do you have a language line or do you have bilingual? Let's say I speak Russian. If I call the company, I'll say, do you have a Russian speaking nurse? Most likely it's no. But then I'll say, do you have a language line that you'll be able to communicate with my Russian speaking patients? Right? Because you don't want to, as a provider, you don't want to give somebody a list of patients they're calling and patients don't understand. That now patients are calling you complaining. So instead of giving them extra services, getting paid for it, you're getting a lot of extra services for yourself. You're not getting paid. So make sure that clinical team is a top notch. You as a provider, the best thing is to let your patients know somehow, email, text, phone calls, that somebody will be calling about this program. It's important for you to participate. I'll be overseeing it, because a lot of times what patients going to say is, you know, Thomas, I just saw Dr. Koyfman last week. She never told me about any program. Let me call her first to make sure that A, you're legitimate, right? Because there's a lot of fraud. And B, that she actually wants me to be, because if she does, why wouldn't she tell me that? So now, if I didn't tell my patients, now I added extra phone call to my office asking about the program, which take away from my time. So provider must be involved. Blast email, text messages, something, say, this is a new program. I'm participating. I love it. I want you to be enrolled. And probably not lastly, but I have to stop at some point. But I would say lastly, you want to make sure you have some sort of escalation protocols built in, meaning, so you outsource your, CCM to the clinical team. Let's say the nurses, which is great. And let's say your patient, you're doing weight loss, and patient is on, Ozempic, and this is a second week, and they keep calling and complaining of normal, unfortunately, side effects of Ozempic, nausea, diarrhea, vomiting, I can't eat, but let's say they're mild, right? But at certain point, when does the nurse have to say, wait a second, I need to call Dr. Koyfman and ask her, or you need to make an appointment right away to see her, because now we're talking maybe bowel obstruction, maybe it's something more than just, regular side effects. Patients that are taking, Lasix, and if they're complaining to the nurse and they're saying, I'm being like too much. What, like, when does the nurse know when she triages like that? Oh, that's important. Like that, I need to get to the doctor versus, hey, this is normal. This is normal. That's what Lasix does. Let's monitoring. Let's make sure, are you eating salt? Are you drinking water? So you want to make sure that you involve because billing is under your provider number. Billing is under you, Dr. Koyfman, whoever the billing provider is. So when they're billing for chronic care management or principal care management, and the nurses are not giving you that information timely, it's your license. So you want to make sure they understand when to call you and how to get in touch with you. So I think those are the biggest thing that a lot of providers are not aware of, and they just jump on. Many providers that I talked to, they were like, "Oh, you know what? This company called me, and they can't do splits because Medicare doesn't allow a split. But let's just say for the sake of, because it's money, $30, $30. They'll say, oh, this company says 50-50. Well, the other company called me and they were 60-40. And then I said, no, no way. I want to make 70% and they're 30. So they focus so much on the money. But I always say, but your license is on the line. If you're getting the cheapest, I always say, if you want the cheapest car, it's not going to be Lexus, right? So you want to make sure that because somebody is giving you the most money, like who are they hiring to work on pennies on the dollar? Who is doing that work? Are they legitimate? Are they compliant? Because Medicare is not going to come for them. They're going to come for you because you are the billing provider.
There's so much nuance there that you've touched
So
upon. So
much. I know. I think we need to do a second webinar just on CCM because
I
we
think
haven't even talked about RPM, which is the
I
cousin of CCM.
I know exactly. So I think what we'll do is we'll keep it high level. I have a feeling there's only so high level we're going to get with you. I think
Right.
there's going to be a lot of gems and a lot of real value
Uh-huh.
in no matter what you're talking about. But I 100% agree with that. Um, but as you said, RPM, remote patient monitoring. Can you tell me a bit more about that and how that interplay exists between its cousin, chronic care management?
Yes, yes. And I did say cousin, but I would say probably more like siblings. Because number one, um, both both programs should work together for almost any patient, and I'll explain why. But before I do that, Thomas, I want to ask you, when you probably Google RPM and it says remote patient monitoring, do you know if there's another name for it? What does RPM could be standing for?
I mean, if I was thinking non-medical, it'd be something like revs per minute or something like that. But I'm
Well,
assuming,
yeah, no, but medical. The RPM. So people say it's remote patient monitoring. It's
yeah.
not. Medicare calls it remote physiological monitoring.
Ah, okay.
Physiological meaning something that your patient has to have. So patients have a pulse, that's physiological sign, right? So you can measure pulse, blood pressure, blood sugar, temperature, weight. There are some spirometers that measure people lung value, lung capacity. I'm thinking, those are like the biggest thing. But I did have people that come to me and they said, for example, we wanted to measure um, steps, right? Because it's like you walking, it's not considered physiological. We wanted to measure sleep. Sleep is physiological, but it hasn't, Medicare has not came out with say, like how do you measure it? So you have to be careful too to not sign up with the company that says we have this amazing new device that measures patients, I don't know, eye color, right? And we can bill for it. And you're like, great. And then Medicare is going to come to you and say no. So remember, it's physiological. Lion's share of patients that are on RPM programs are doing blood pressure monitoring because almost every elderly patient has blood pressure. As we age, our arteries become stiffer. It's called arteriosclerosis. And unfortunately, we all predisposed to have hypertension the longer we live. There are a few things, of course, people can do, exercise, diet, but normally majority of Medicare patients have hypertension. And I'm not going to bore, you guys know, but 50% of American adults have hypertension, but almost 50% of those do not know that they have it. So that's a huge problem. I'm a big advocate of RPM for blood pressure. So anyway, so it's a blood pressure machine, let's say, or scale for the weight or whatever, pulse ox, which I feel like it's completely irrelevant because what can you do with pulse unless you have, AFib? You might as well have a, blood pressure machine that does both pulse and blood pressure. But anyway, so remote patient monitoring, the way it works is you also have to consent patient. You have to tell them about the program. There are things you have to discuss, and we can go into that later. What is the right consent? Because if you just write in an EMR, Thomas, that Irina Koyfman agreed to participate in RPM program, it is not considered legitimate. Medicare can actually come and take all the money back because Medicare says in a consent, you have to discuss three things, and it's for CCM and RPM. And those three things are the one that's amazing, patients love it, is, hey, Thomas, you can stop at any time. Great. Two, they're saying only one provider can bill for it per month per patient. So you always have to ask patient, do you have any other devices or, any nurses, anybody calling you from another doctor? So you have to make sure that that's, you ask that. And third, which is the most important, the most frustrating for everybody and the most complicated, is the cost sharing. Medicare says in your consent, you have to discuss cost sharing. What does it mean? Well, Medicare only pays 80% of every, 80 cents on every dollar you bill. So then patients have either secondary insurance that covers some or portion, or they pay out of the pocket for the 20%, or sometimes they have the Medicare Advantage plan that's kind of all encompassing, but they might have a deductible and copays. If I knew how to crack that nut, Thomas, I will be living in Hawaii drinking margaritas right now because nobody knows. It's like, I have owners of RCM company calling me and saying, tell me how much United, does United so and so covers? Like nobody knows because there's so many different plans within each plan, with each provider, each employee. It's a nightmare. But you have to discuss this with patients. So if you have a Medicare patient and they have a secondary, you have to say, Thomas, it looks like you have Medicare and medical assistance, in the state of Maryland, it would be full coverage because the Medicare pays 80, Medicaid pays 20. You shouldn't be occurring any charges, but you have to explain that. So imagine when you have a patient that you don't know, like Blue Cross and Blue Shield completely dropped RPM at the end of May when PHE ended. That was a shock for everybody. And you don't know that until you know that. But now that we know, if patient has secondary Blue Cross and Blue Shield, you have to say, I know you have secondary insurance, but Blue Cross and Blue Shield does not cover RPM. So it might cost you $12 to $24 a month. And then you wait for patient to say yes or no. So you have a consent, and then you either ship the blood pressure machine or people pick it up from your office, whatever it is. But then there are a few things that has to happen in order for you to bill. One is you have to have a 16 days of reading in a 30-day cycle, not a month, which is ridiculous. It's in 30 days. So what does it mean? So Thomas, if I say 16 days of reading, forget about 30-day cycle, and you measure your blood pressure twice a day for 8 days, do you think it's 18 days of reading?
No, I'm
Okay,
gonna.
I just gave you. You're too smart, but I also gave you. But
Intuitively, I might say yes,
it's
but I'm guessing
well,
it's
right.
not the
So a
case.
lot of people measure their blood pressure multiple times a day, and a lot of companies. So you have to be careful, clinician. They'll just count and they'll say this patient had 29 readings. Well, you have to make sure it's days because 29 readings. I had a patient that was taking 11 blood pressures every day. God loves him. He loved that machine. So 29 readings could have been done in a week. So you have to make sure it's 16. So 16 days of reading, you bill for one CPT code. It's about $55 per month per patient. And then if you spend 20 minutes kind of managing the data, looking at it, analyzing, you have got to talk to the patient within that 20 minutes. It's called interactive communication. So you have 20 minutes, you didn't talk to patient, you can bill. You talk to patient for 19 minutes, you're not at 20, you can't bill. So the 20 minutes collectively has to include a phone call. So for that 20 minutes of data management, including a phone call, you bill another, let's say $55 per patient per month. So it's pretty lucrative. But as a provider, you have to buy the machine because nobody, you buy it. That's why you're getting reimbursed for 16 days of reading. And you also have to pay for the platform because the machines are cellular and they have, or Bluetooth, but they either have a chip or the Bluetooth where it connects to the platform so you can see the data automatically. Medicare said that you cannot bill for RPM if people call you and say, these are my blood pressure numbers or blood sugar. They can't even take a read, they can't even take a picture and send it to you because Medicare is very clear. They said it has to be real time synchronous real-time data flow. So a patient takes the measurement and real time it comes to your platform. So you do pay for that. And the prices are very different too, but it's somewhere around 20, let's say $20 per patient per month. So, but if you combine CCM and RPM, so imagine when you're a clinician, you're seeing blood pressures. I mean, I was able to titrate medications, change the dosage and dates, times of medication given to stabilize my patients. If I didn't have that, I would be adding another medication because, people take their medications usually at the same time, like let's say in the morning, let's say they measure blood pressure in the evening, or they measure it in the morning, it's still high. I'm adding medication, but now that I see, wait, the blood pressure in the morning is high and in the evening is lower, like way lower. When are you taking your medications? Oh, I'm taking both lisinopril and metoprolol in the morning. Okay, well, great. Keep metoprolol in the morning, take lisinopril at night. Now it's stabilized. So it's a lot of clinical data. It's amazing. It can really help you become better clinician. Patients love it because all of a sudden they can get off the medications. If you have a good clinical team, they talk about lifestyle changes. I mean, I had patients losing 40 pounds in 6 months because nobody, like people don't have time to explain, right? And sometimes it's, you can explain, but they don't have the means, right? It's like, okay, I had a patient who was constantly, in and out of hospitals for congestive heart failure. She was always overloaded. And all we did was keep increasing her Lasix until I actually talked to her. And she told me that. So people asked, like, do you have a car? And she said, yes. Well, the car she had was not driven for the past 10 years. So she never lied. She's like, I have a car. It's in my garage, but I can't drive it. So she really relied on the next store next to her that she could walk to. And there was 7-Eleven. And in America, you guys know 7-Eleven, you can buy a bag of chips for $2. You can buy one banana for $1. What are you going to buy? Right? Like fruits and vegetables are very little there and very expensive. So
Yeah.
with her, it wasn't the lack of knowledge, it was the lack of resources. So I set her up with Meals on Wheels and she was not readmitted again. And this is what like that the programs, let's say CCM or PCM and RPM can do for you as a clinician. It gives you the person to really talk to the patient, really understand their issues, why certain things happening, kind of look for the root cause, try to, really work on it, right? So if it's resources, there's so many resources available now. You go to findhelp.org and it's free site where I can put patient zip code and find anything I want for free, right? The churches that have food pantries next to that, like anything. So it's not that we don't have it, we just don't have time to do it. So now you have a clinical team that can do it. You have the data, let's say from your blood pressure, you can really manage, people's blood pressure better. At the end of the day, everybody wins. But you need to do it right and you need to do it with integrity.
Yeah, there's so much there, but what I actually love what you said there about the 7-Eleven
Uh-huh.
point, taking that holistic approach and realizing just thinking outside the box, outside of the purely medical side of things,
Yeah.
just the real logistical elements that actually do get in the way of people. I think that's you wouldn't get that sort of insight with just one interaction. So I think that is a really, really powerful ripple effect
Yeah.
of that combination. Um,
Yep.
with this being said, are there particular clinics, particular characteristics of a clinic that you believe will be really, really suited, to taking on CCM and RPM?
Yeah.
Are there specific kind of factors that would to you would signify right? The,
Yeah.
it's time for these guys to start implementing this.
Right, right. So the answer is honestly everything, but big caveat. I would say number one, like primary cares are the best. We are the least paid, the most overworked, the busiest. Like you have to know everything about everything, and you only have so little time. So I think implementing it in primary care would be just amazing for, everybody. And then specialist. I always say if you're a specialist, you should never be billing CCM because Medicare is clear and a lot of people are not aware of it. Because in order to qualify for CCM as a patient, all I have to do is have two or more chronic conditions. So a lot of companies and providers think, oh, okay, well, it's just two conditions. So anybody has two or more conditions. Let's say, Thomas, you have diabetes and hypertension, right? but you also have obesity, high cholesterol, hypothyroidism, and maybe arthritis, they will do care plan just on two diseases because they're like, oh, all you need is two. It's not right. Medicare says in your care plan you have to address all of patients' problems. So this is why when specialists will ask me and they'll come to me and they'll say, like, I'm a cardiologist and I am managing hypertension and CHF. And I said, well, great, but if patient has a flu or a cold, is patient going to call you or primary care? Well, primary care. And I said, well, then you can't have a care plan with just two diseases. Like it's just not, I would say it's not kosher. I haven't heard that Medicare actually came out under anybody that only has two diseases in the care plan, but it's been too little time and we don't know. And I like to say, if there is a gray line, I want to be as close to the white as I can. So that's kind of grayish line, even though Medicare says every problem needs to be addressed in your care plan. So that's not it. To me, it's black and white. Um, so I would say for specialists, I would do principal care management, which is one disease, you focus on it. And so I see RPM and PCM huge in cardiology, right? Because they take care of people, that cardiology, blood pressure, hello, like that's pulmonologists do spirometer for asthma and COPD. Endocrinologists can do blood sugars for diabetic patients. Um, Cardiologists can do scales for CHF, but honestly, in terms of RPM, not every specialist can do it because remember, again, it's physiological parameters, but PCM or CCM can be done in any specialist. If you feel like especially if you're working a lot with pre-authorizations and you're spending all this time by your MAs just, chasing like a huge problem, like weight management right now, it's huge. Everybody gets denied of their, GLP-1s. And pretty much, I heard it's about 90% strict like denial. It's like written like no, unless they have diabetes. And even then, it's kind of questionable. But then you have to appeal. And after the appeals, it works out a lot of times, but then you're not getting paid for it, right? If you're just doing weight management and you're not billing for PCM, you cannot bill for all the time that your MA or whoever is doing pre-authorization, denials, letters. So I think that should be like number one thing, like add PCM to what you do, and then you can actually get paid for the work that's being done.
Brilliant. And then with regards to, again, we talked about CCM at the start. With regards to implementing the RPM side of things,
Hmm.
as you said, has to be physiological, so there are inherently some sort of barriers.
Hmm.
What strategies have you found successful when it comes to overcoming, perhaps those the adoption of RPM technologies, amongst staff and patients alike?
Um, So, I mean, it's hard to say. I think, as a leader, like transparency is number one. And if I own the clinic, I would get a team meeting and I would say, look, guys, uh, we're going to do this. It may add a little bit to your plate. However, as a clinic will make more money. And out of that money, I will be able to pay for your overtime, give you bonuses. Patients are going to be very happy, and we're all going to be happy. So I think transparency, you never wanted to implement something where your staff is not aware as to why you're doing it and like who's going to do it and, what the responsibilities are. And I also think that anytime you add something that on top of what they're already doing, people need to be reimbursed. Otherwise, it's just going to be a lot of negative, reiterations. But again, you're getting paid for it. So now you have this extra income. And remember, you're getting paid for the job that it's already being done. You were never collecting the money. So it's actually a lot more than you think. It's not just what you're getting paid, but it's also the time that you're billing for all the work that you've done and you won't be able to get paid. So I think just transparency and always, I like, Simon Sinek, like his 5 whys, like always explain to people why you're doing it and bring them the data, bring them the stats, say like patient satisfaction is higher and that's important to us because we're getting dinged by whatever negative patient satisfaction and we're getting RVUs and we're getting paid. So those are things are my thing. And also as a provider you have to do a lot of research and really understanding if you're outsourcing, who are you outsourcing to, and if you're doing it in house, hire a consultant, somebody that can actually help you build the program. Because what I told you, Thomas, about social determinants of health, this is my personal passion because I've always been in that space of really complex patients, the readmission problems. And I was always trying to find a way to look at them from a different lens, not how I can make you healthy, because that's essentially impossible, but what can I do to make sure your quality of life is better? And what can I do to understand you a little bit more? What can I do to make sure you don't get back to the hospital? And then if you look at it from different lens, then I realized, I was like, whoa, like it has very little to do with their medical condition. It has more to do with the social determinants of health. Because if they don't have a card to go see the provider, it doesn't matter how many discharge teachings you're going to give patients, right? Somebody needs to reconcile their medications when they're back home. So when you're outsourcing or when you're doing it in-house, make sure that you're also understand and knowledgeable about what it is that patients really need and crave, and where's the gap. And as providers, we're not thought about social determinants of health, let's say, but it's becoming a lot more evident. So, you need to do your due diligence to make sure that your nurses or whoever you hire are not just calling and saying, hey, Thomas, how are you? What's going on? Have you gotten your medications? Is there anything I can do for you? And if you say no, I'm like, okay, well, great, I'll call you next month, which happens a lot. And if patients get no value, then they stop picking up the phone, and then you can't bill for it. And so you lose the business, and patients like, well, that was bullshit. Like, what was that all about? So you really want to make sure that you provide value to the patients, and you're going to feel much better about getting that money from Medicare and insurance because you know the value that you bring.
There's so many things that I love in terms of your philosophy with all of this. The second you mentioned Simon Sinek, I was like, right, we're aligned in values here. Eat leaders eat last and all that kind of stuff that he's such
Yeah.
a big advocate of. But what you're talking about reminds me a lot of what some previous guests, one in particular, Ken Mitchell, on a previous episode mentioned. He said, if you take care of the patients, the money will always look after itself. And that, you know,
Yeah.
in its own way is very reminiscent of what you're saying. Legitimately being invested as to what assets and resources these people have at their disposal does reap the benefit, because if you do view it through that very narrow lens, you really are shooting yourself in the foot financially, and obviously everyone's worse off in the long run. But again, circling back to something you talked about earlier on, and I think I'd love for you to elaborate on a bit more. I think people get a lot of value. Is you mentioned with CCM, there's a lot of really useful tools and pieces of software that can augment the process of making that efficient. Do you have any examples or personal tips and tricks that you
Yeah.
and for people?
Yeah. I don't have the statistics in front of me, but I was doing a webinar and I literally just Googled CCM platform. I don't know if you can do that right now, Thomas, just to see. And I think 300,000 um, came out as like available platforms. It was like enormous amount, and they're growing like mushrooms. I've had calls, especially when kind of CCM just came out. I will never forget this one, and I had very many of similar one. The guy who said, "Hi, I was doing consulting. I would like to consult with you. I'm building, or I built already CCM platform." And I said, "Well, great. Like, tell me a little bit more how you got into whatever, whatever." Okay, well, I worked in Epic for a year. My father is a cardiologist. So we came together and we're like, oh, we can build this because I know Epic and he knows cardiology. And I was like, okay. And I said, well, let me see. He didn't have a care plan. Let's say there was no template. And I said, well, do you have a care plan? And he said, no, 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 no. Doctors will write it. Like that, you don't have to worry about it. And I was like, well, that's not. I mean, the whole point is like nobody has those care plans. Like you have to like have them in your platform. Um, Another company that came, they didn't have a timer. And I said, well, how do you know? Oh, the nurses, they just write. Like I started right now, and then and I'm like, well, okay, so what are you offering them? Like what are you selling them, right? It's like calculator without the
The
numbers.
numbers,
Right.
yeah.
And And you'll be surprised how many were so they were in such an infancy. And the problem was that they were not smart enough to hire a clinician, like somebody like me, to consult them initially, because they didn't have the money. What they wanted was to build the program and then show it to somebody like me for like a few $100s to say, yeah, just, add a little bit here or change a little bit there. That would be great if it had a lot of things. But if it was like not useful tool, I was like, whoa, you just spent $200,000 building this tool that doesn't qualify for being like CCM platform. They didn't want to hear it. I was like, I don't want to deal with you either. Like, goodbye. That's not, I don't want my name next to something that's not. So there are so many platforms. So one thing I want to tell you right now, the way that you can get a platform is either you pay per patient per month, and it's somewhere between as little as like $2 and maybe 50 cents from what I heard. The lowest was up to like $5 per patient per month to use the platform. Or there are a few companies that do like a flat fee. You pay either, I mean, I've actually heard one that was only $200, but it's for each clinician. So it depends. If you only have one or two, that's fine. If you have a lot more, you have to think about it. Or you pay like, $600 per month, but you get up to like 10,000 patients or like 1,000 patients, I forgot. So you kind of have to do the math and see what's better for you, pay per patient per month or pay like a monthly sum. So those things people don't know, because if you demo three companies and each of them are pay patient per month, you wouldn't even know that there's other companies that you can just, charge, pay one fee. So my biggest thing is like you have to do your own work and you have to demo them. I'm not sure what it is you like. You have to have a timer. You have to have a care plan. You want to see, make sure that it's cute and user friendly. The biggest thing is, can they integrate with your EMR? Because if they can, and everybody will say absolutely yes, 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 yes. But then you have to ask, how long will it take? How much will it cost? And somebody will say it's going to take me a year and it's going to cost you $25,000. You're not going to want to do it. So you really want to kind of, make sure, because if I'm a provider and I'm outsourcing it to you, Thomas, part of your care plan is all the patient medications, all the history. You like, how are you going to get that? So you want to make sure. Some people do like a data dump, which is fine. So find out if they do data dump or EMR integration, but the care plan has to have a lot of information that's in your EMR. And if it's not, then it's not compliant. So that's the second thing. And the third is, I would say, look for the companies that there are so many companies that provide like free trainings on everything. Like, what is CCM? How do you scale it? So, maybe you pay a little bit more, but it's better than getting a cheaper, let's say, platform and then paying for somebody like me to come and, teach you how to use it. Because just because you have a platform doesn't mean like they might show you where care plan is and whatever, but they'll never tell you how to talk to patients, how to get them consented, what is the best way to sell the program, like all that stuff. And there are platforms that do, to have that training already kind of built in. But it's a lot. And I always say, I'm sorry to say that, but I would never say use this company or use that company, because you have to do your own research. You have to demo them. You have to see what you like. And also, don't get what I call one trick pony. There's still platforms that only do CCM, and there's still platforms that only do RPM. Since I told you that two programs can and should be done together, and even RTM, which we haven't even talked about it, which is another program. It's remote therapeutic management, but you don't pay for anything you don't use. But if you want to get it and you think, oh, maybe in a year, maybe in 6 months, I'm going to implement RPM, because I always say, don't do everything together. It's too much. If you're new, learn, do one program at a time. Well, then you don't want to hunt for another platform. So try to find something that has at least two modalities, and then add the one, pay for the one that you're going to use later, but don't get one that only does CCM, one that only does RPM, unless you are absolutely sure that that's the only thing you're going to do.
Yeah, and great advice, as per usual. But we'll one or two quick questions, and again,
Yeah.
I want to be respectful of how I have. But one is, I suppose, where do you see that the trends of these going? With all this technology, are there specific future trends in healthcare technology in general? Because again, I'm sure there'll be plenty more
Mm,
conversations uh,
yeah.
that you believe will have the biggest impact on RPM and CCM. And is there anything that clinics can do today to prepare for those changes, or is it
Mm,
just a case of keeping your finger on the pulse,
right.
metaphorically and
Yeah,
literally?
yeah. And yeah, great question. Um, I wish I was that knowledgeable, Thomas, to tell you. One thing I can tell you is that the projection for RPM is tremendous. I don't have the numbers in front of me, but it's like doubling, tripling, quadrupling every year. I read somewhere by 2030, it would be gazillion patients on the RPM because there's tremendous benefit to it. So I always say, if you're not an early adopter, at least jump on the bandwagon now. Don't be, 5 years after everybody has already implemented it. And then your patients are like, I'm moving to the doctor that has the blood pressure machines for me and, provided extra layer of support, which I have heard happening. So get on it. I know it's going to just keep getting, bigger and better. With that said, I think the technology is going to get better. I think that and cheaper. Like right now, cellular blood pressure machines cost about $100 per machine for a provider. So that's a lot of money. I think they're going to get cheaper, better. I think Medicare is going to start allowing more things like, like Apple Watch was approved to do RPM, but only for Alzheimer patients with Alzheimer's or atrial fibrillation. I think at some point Medicare will recognize that they might lower the fee schedule. They might pay a lot less, but they might say, you know what, Apple Watch, can be part of RPM because like to me, if we're talking about patient benefit, it's like now this is more of a provider benefit, right? But if I have a smartwatch, like why would I want to get my blood pressure check, twice a day if I can get it done on my watch all the time? So I think there's going to be more kind of physiological parameters that Medicare may pay for it. I also think that there's going to be like there are many companies now that do like a cellular hub and then you can connect multiple devices to it, which I love. I would say as a provider, if I can get for the same price a blood pressure cuff, pulse ox, and maybe glucometer, if patient has diabetes, then oh my gosh, like why not, right? It's a one cellular hub and three little Bluetooth devices. Um, but I think the biggest what I'm trying to get more information in and understand is obviously AI. Like that's what's gonna really blow up, and it's gonna be part of probably every RPM company because right now you need nurses to like monitor, see the trend, call the patient. You get alerts if it's too high or too low. But what happens when it's not too high, but it's high enough? So I think AI is going to be huge. So really trying to like understand more about, how it's going to be impacting. But I just think that I don't perceive Medicare ever like stopping or making it less, but since Medicare wants pretty much everybody to become like a value-based in value-based managed care by 2030 or 2032, some managed care companies, I'm afraid, are going to want to provide that service themselves versus providers. So instead of doctors, they'll send the machines and monitor, which I think would be detrimental to the providers. uh, I'm not sure. I'm not sure if it's going to be better for patients or worse. I think worse, because anything that comes from insurance company doesn't have that much rigor. So I don't know. All I know is right now it's going strong, and I think getting on it now, I think we'll probably stay for the next 5 to 7 years, but I don't know. But with that being said, Thomas, Medicare came up with a lot of new programs this year, like uh, uh, patient illness navigation, caregiver training for patients that have dementia, which Medicare never ever. Let's say if like my father has an end stage dementia, if I didn't bring him to the doctor's office and doctor just talked to me, they would never be able to bill because they were like patient needs to be present.
Mm.
Um, but now we can bill for training of caregivers. So that's another thing that we should discuss. And utilizing community health workers for that social determinants of health. So there's a lot more that Medicare is now developing and paying for that is totally outside of our traditional brick and mortar, come and let me see your medications and let me measure your blood pressure in the office. So there's a lot more in that kind of management of the patient that is coming our way.
Stay tuned.
Stay tuned.
There's again, there's so many different ways you can segue this, and
Mhm.
I have one final question for you, Rita, and this is more so a bit more of a personal one, but I'd
Mhm.
love to just hear a bit more about it. You know, beyond the financial and operational benefits, obviously with all these different things, um, are there any particular personal experiences or moments that really shaped your passion for advancing RPM and CCM in healthcare? What's your mission? What's driving you forward uh,
Yeah,
today?
yeah, that's a great question. So, as a provider, I was in the same boat, and I also almost like got tired of, hearing my colleagues kind of, what's the word that I can say without cursing?
I don't want
Complaining,
to.
bitching and moaning, complaining about like all the work that had to be done, and was not reimbursed. So I mean, that's how my entrepreneurial blood. I was like, I'm sure there's something I can find, and I was just lucky that the time kind of, if I did it in 2014, it wasn't there, but when I did in 2017, it was there. So um, I like to personally help providers because I feel like we're like everybody's burned out, like when you hear it. And again, that's why I became, stress management guru too, because I feel that if you don't have the tools to build your resilience, then you can't really help your patients, right? Because if you're anxious yourself and stressed out and tired, you're going to miss things. You're going to be not careful. So things are going to be bad for you and for your patients. So, I found that, and by teaching just so my very good friend who does, primary care, I taught her about CCM before anybody knew, and she started doing it and she started billing for it. And she's so happy. She tells me that all the time. She was like, I make so much extra money for doing what I was already doing. And it also helps me to like slow down and spend more time because I don't feel as pressured to run and see yet another patient. So I think my passion is to really help the providers to gain that financial benefit, but also, the clinical benefit for the patients. And, I just see tremendous benefits that patients receive, especially with RPM. As I told you, medication change, dose adjustments, people getting off medications because now they know what to do in terms of exercise and eating, they're losing weight. So just it's been positive all along. What is disheartening is companies that start doing that just to make money. Like I told you, veterinary tech, who is a manager, companies that I heard somebody is charging like $15, $15 per patient for CCM, for RPM, which is very, very little. And I'm thinking, how much are you paying your staff and how involved are they? And are they, I've heard from nurse that came to job interview with me. She came from another like really, really big RPM company, no names. But she was like, I can't do this because I come in the morning and they give me spreadsheets of patients that I have to call. And as long as I make the phone call and I document that I talk to them, like it's billable because somebody else does the data. So she's like, I'm not really seeing the data. I don't know these people because there's no connection, there's no dedication. And she left. But that's the disheartening part is that when people just do it for the money, it's it's really bad for everybody, clinicians and patients. So, I always say if you do it, you're getting paid well for it, do it with heart, do it with integrity, do it with, you know, with with best intentions. And I always say, if people that do fraud would just put that time and energy into making something work because they're brilliant sometimes when they do all these, combinations and like I was like, if you just put that time and energy into making it right, you would probably make more money and you can sleep very easily at night. You don't have to worry that you can get arrested and any moment. So I always say make sure that you do it with integrity, but also when you're hiring somebody or you're outsourcing it, that you really talk to them and you really understand that they're not, I mean, it's a business, right? Everybody wants to make money. I'm not saying that, I'm not marking it. It's great. I love money too. I make money too. But there's a way to make money with integrity. So that's kind of my passion.
I love everything you just said there. So there's
Thank
nothing
you.
that I can add to it. And it circles again back to the whole thing,
Yeah.
cutting corners in healthcare, especially when it comes to this. It's patients pay the price, literally and metaphorically.
Yeah,
And as you said, take care of the patients, the money will look after itself. And as you said, you'll sleep a lot better at night. So I think you're on a great mission, and it's been an honor and a pleasure get a little tiny glimpse of the insights that you have. And I'm really looking forward to hopefully getting to have many more of these where we can break down some of the specific
yeah,
subtopics, and hopefully helping a lot more people break into the CCM and RPM world. So um,
amazing.
that being said, I suppose where can people find more about you, Irina, and what you do?
Um, I think they could just Google my name and see where I am. I'm really not in I'm not really consulting anymore. I do it just with love and people that I know that I like to help out. But I'm just here to spread the world, to spread the love. And if anybody just needs to ask me a question, feel free to find me. I'm on LinkedIn. I have a website. And then, I can always connect you with somebody that actually does do consulting now in CCM and RPM space.
Irina, that being said, it's been an absolute pleasure. Thank you so much.
Thank you, Thomas, and good luck to everybody.
Perfect. Thanks.